Good morning, ladies and gentlemen. I am Dr. Thuy from Hanoi Medical University Hospital. Today, I am honored to be here to share with you some about experience about rare neurological disease. It's about the Hirayama disease in Vietnam. Hirayama disease also had monomelic amyotrophy or juvenile non-progressive amyotrophy, which was first described by a Japanese neurologist, Dr. Keizo Hirayama, in 1959, capturing attention of the researcher worldwide due to its distinct clinical presentation and underlying pathological. Less than 1,500 patients with HD was reported in the literature, mostly distributed in Japan, other ASEAN countries, Europe, and North America. Combining clinical evaluation with EMG and MRI finding as us in establishing the definitive diagnosis. The clinical feature of the HD was similar to those with the amyotrophic lateral sclerosis, the cervical spondylolysis amyotrophy, and spinal cord infection, or SCI. The pattern of the muscle atrophy in the late stage of the both conditions was similar. Our case series aims to describe it and compare the clinical feature and electrophysiological and MRI finding of 9 patients with HD and 2 patients with C7 and D1 segmental spinal cord infection. We will repeat some criteria for diagnosis of Hirayama disease. First of all, the patient shows the weakness and wasting predominantly in C7, C8, and G1 myotome in one upper limb or asymmetrical in both the upper limbs, insidious onset, or appear in the early 20 years old, who was progression for 1 to 3 years old, then followed by arrest of disease or a relative benign course. The patient shows irregular cross tremor. Now we describe this phenomenon with polymyoclonus. The patient show also mild transient worsening of the symptom with exposures to cold, and there was absence of sensory abnormality, cranial nerve palsy, or pyramidal tract size. In this case, we describe a 18 years old male patient who shows the typical clinical characteristic of Hirayama disease. First of all, polymyoclonus in the upper limb. Sorry. How we show the video. Yeah. Okay, not to play. Sorry about this. So we cannot view the video which shows the irregular tremor at the extremity of his upper limb. But this image shows us the amyotrophy of the forearm muscle with sparing the brachialis, which was the most important characteristic feature. And then we can see the next slide. The amyotrophy is predominantly at the muscle, weak enough by the ulnar nerve. which shows the inverse, the reverse split hand index, the interosseous and the ADM muscle was predominantly amyotrophy compared with the muscle innerved by the median nerve. In this table, we resume some clinical profiles of the 9 patients with Hirayama disease. Sorry, we can't see anything, but in this table, we show that the minimum age was 16 and the maximum age was 21, and all patients was males. The muscle was predominantly infected, was ADM and first interosseous muscle. Most of the patients shows a cold sensitive and irregular tremor as the upper extremity. Because of the weakness predominantly in the ADM, so the most of our patients show the Wattenberg size, and the duration is from 1 year to 3 years before the progression was stable. In the electrophysiological profiles, in this table, you can see the CMAP as ADM was predominantly decreased compared with the ABP CMAP. All the patients shows a nerve conduction velocity in the normal range. When we perform the needle EMG, we expect the lesion in the myotome C7, CS, and T1. Spontaneous activity, most of all, shows fibrillation and fasciculation, and the chronic neurogenic trends at the myotome, and the brachialis always normal in the needle EMG, and with the dynamic MRI, he shows a characteristic with anterior shifting of the neural cycle, and there was the flattening in the anterior horn at the lever of C5. This table shows a characteristic of the MRI finding. There was the localizing cervical core atrophy, asymmetrical core flattening, lots of attachment between the posterior neural cycle and the subjacent lamina. The flow void in the epidural space explained by the increase the blood vessel in the vein at the epidural space, and no one shows the intramedullary sign of hypertensity. In this slide, we describe a 26 years old female with say S and T1 spinal cord infection. In this video case, there was a video, but we can see now. There was a paralysis of the abductor pelvis APP. The symptom was appear suddenly, and in the MRI with the diffusion shows the hypersignal in the diffusion at the S and T1 spinal cord infection. So the SCI and SD were in the late stage. We show the patient shows a similar pattern of the muscle atrophy. The clinical profile of the 2 patients with CS and D1 ischemic. So with a predominant atrophy and weakness in the ABP, but not in the ADM. So the split hand index was similar with the ALS. There was no cold sensitivity, no tremor. One shows the water size and the duration is short. So in the MRI, we see the previous slides. In the nerve conduction, the CMAP of the ADM is more preserved compared with the ABP CMAP. And the needle EMG shows the acute change in neurogenic pattern. In conclusion, all of 9 Hirayama patients was male aged from 19 to 21, while 2 spinal cord infection patients was females aged 22 and 27. 80% with the asymmetrical weakness of the upper limb muscle, lots of physical cervical lordosis, and long neck morphology in all patients, mild hand tremor and exacerbation of the subdominant cold. Although the pattern of the muscle atrophy in the late stage of both groups was similar, the SD has the predominantly involvement of the agitated dizzy time minimum and the first interosseous, whereas the spinal cord infection patient has a predominant involvement in the median side muscle. Abrupt onset of the pain symptom and rapid muscle atrophy were only observed in the spinal cord infection group. Lower ulnar median compound muscle potential ratio in the spinal cord infection group. Thank you for your attention and sorry about the technical problem.